Okay, welcome everyone. So excited. I know folks will still be joining us, but want to kick this off. Before we officially get started, I do want to share one of our wonderful volunteer members of the coalition created a promotional video about today. Thank you, Steve Hahn. And I'd love to go ahead and show it to everyone right now if you haven't already seen it. So are you seeing this now? Let's see. Okay, I got the thumbs up. So let's play it. It seems it's lovely. Was everyone able to see it and hear it? I am interesting because I can't hear it, but great. I'm glad everyone else could for sharing. All right. Well, I am thrilled to get started. Welcome to the final session, the last day of our second annual Joining Our Voices Symposium on envisioning the future of serious illness care. I am Heather Altman. I see a lot of friends here, so you know I am the executive director of the North Carolina Serious Illness Coalition, and we are thrilled that you are joining us for the last day of our symposium. For some of you, you get a gold star for attending all 5 of our sessions that we've had this week. So we'll figure out, and we should send a little something for those of you who've been with us all week. Please take a moment to put your name and your organizations, if you're coming from an organization, in the chat. The chat line has been active this week, and I don't expect anything different today. Put your name, your organizations. You can also put questions, and both Marisette and I will be looking at that throughout the session. The other thing is other logistics. Keep your microphones muted, and the best viewing, for your viewing pleasure, the best viewing will be on speaker mode. If this is your first time joining a coalition event for the North Carolina Serious Illness Coalition, we are a statewide partnership to advance the quality of life and the quality of care for individuals and families touched by serious illness. Through collective engagement of our active work groups, we address clinical practice and quality, advanced care planning, and caregiver and patient engagement through a variety of communication, advocacy, and education efforts. You are all welcome to join the coalition. You can learn more about us at our website. It's up, okay, there, weather person, up over there, ncsicoalition.org. You can also go ahead and put your email in the chat line, and I will make sure to add you to our coalition listserv. There's no cost to join. We just would love to have your engagement and your insights. So many thanks. I want to put a thank you out to all of the coalition members who helped to create this week of wonderful programs, and many of you are on now, and there were many folks that helped behind the scenes. I see our friend Steve Hahn just joined us. Steve, we did show the promotional video just now that you created, so thank you so much for this event. I am now super excited to I'm always super excited, but I'm really excited to turn it over to my, someone who has become a very good friend of mine. We've become quite the partners here. Marisette Hassan is just a wonderful friend and colleague and member of multiple coalitions, and we'll talk about that in a moment. I do want to give a little shout out to her background and her experience and her fabulous connections with lots of important communities and work groups, and then I'll turn it over to her. So Marisette is a nurse by training and is the principal and CEO of LifeSprings Consulting Group. She is passionately engaged in supporting hospice and palliative care providers and policy advocates to increase access and decrease end-of-life disparities, particularly for patients and caregivers who live in Black and Brown communities. In addition to her role as vice chair for the Alliance for a Healthier South Carolina, Marisette serves as program coordinator for the South Carolina Coalition for the Care of the Seriously Ill, which we lovingly refer to as either our sister, I say our sister coalition, you say our cousin coalition, but we are family coalitions. We're so excited to work together. Through her leadership in South Carolina, the coalition oversees their My Life, My Choices grassroots advanced care planning initiative that's funded by Blue Cross Blue Shield of South Carolina Foundation. And then for us here in North Carolina, and I was just with her at a church last week, Marisette educates communities through our own community care program grant connected with Health Sciences Health Innovations Group and the Mind My Health platform. She'll be sharing a little bit about that. And this work is funded here in North Carolina by the License to Give Trust Fund Commission. Marisette is a rock star nationally and all throughout the national level. I saw for myself at last month's Coalition to Transform Advanced Care Conference, otherwise known as CTAC. She is the Vice President for Community Action and Policy with CTAC, and she is Community Co-Investigator for the Equal Advanced Care Planning and Equal Space African American Faith Advanced Care Planning Research Projects, led by Dr. Kimberly Johnson and funded by the Pecori Foundation. I have been so fortunate to work with Marisette, and I am not joking. When I was in DC and I mentioned I was from the Carolinas, multiple people were like, "Do you know Marisette Hassan?" And I was like, "I do know her." So she really is, we cannot understate, and I'm so excited that we have such a national rock star here in the Carolinas and here working with us both in North Carolina and South Carolina. It is a fitting end to what has been a truly meaningful and thought-provoking symposium this week. We looked at how we build our villages to support aging in community. We talked about how to learn from caregiver support programs, specifically those run by the Veterans Association. We learned how to address advanced care planning in innovative ways, including the use of video advanced care directives, which was so powerful. If you, a lovely woman shared her personal video advanced care directive, and we're excited to put that on our website. And then yesterday, we had a wonderful session on our roles with universities and the roles that they play in educating a range of clinical disciplines and having goals of care and advanced care planning discussions. And I know from my late night chat with Marisette yesterday, she's at Duke right now talking about things. And I know that she just educated a group of graduate students about goals of care. So it is just wonderful to pull this all together. And I know she will weave in a lot of these ideas of this whole week into her talk. And so now I will stop talking and I'm going to turn it over to Marisette, and I'm going to share my slides because I'll be her slide advancer. So welcome, Marisette. Thank you for joining us.
Hi. Well, Heather, thank you so much for the warm welcome and the introduction. I am just one of the colleagues from the Carolinas. Absolutely glad to be with you guys here today. My roots are in Carolina. I mean, I've been living in South Carolina since 1969. And of course, for the years of my career, absolutely have loved working with the hospice and palliative care community. I see some of the South Carolina folks that are on along with the North Carolina folks. So shout outs to everyone. And especially this month as we recognize Hospice and Palliative Care Month and home care, I want to just really give a shout out to all of the folks that are in the trenches taking care of our very seriously ill patients at the end of life. It is one of the great joys and passions of my life, this work that we do with families and caregivers, and more so doing more work with community. So very glad to be with you today. And I get the opportunity to do that across the Carolinas. And then I get a chance to also interact with our provider community, as well as our national folks that are working on policy things on the national front. Today, we're going to be talking about how we empower tomorrow, looking at navigating the future with advanced care planning. I find in this season of my career where I sort of come full circle and I've been in nursing long enough that I can give maybe a few pearls of wisdom, right? We want to encourage you to be very interactive with us today. Put your questions in the chat. You can also put your amens in the chat if you want to. And as most of you know, not only have I worked in the space, but personally also have a family and do a lot of that as well as work in my faith community. Next slide, Heather. Thank you. I hope that everyone can hear me. I'm going to start off with just sort of talking about advanced care planning in terms of my own journey from the past to the present. The first picture you see there is a picture of my grandparents, John Henry and Ada Bodison. They were born in 1903 and 1905. They are both deceased now. But that generation, I remember meeting them in person when we moved south in '69. My parents were in the Air Force, and so we traveled a bit. And we moved south after living in Anchorage, Alaska on the Air Force Base and moved to a little small town called Rondo, South Carolina, where I got a chance to spend the rest of my years growing up in the Carolinas. And my grandparents, both who are deceased now, their culture was not really to talk about death and dying. You know, both of them died many years apart from each other. And our culture, in terms of our family culture, was to really keep everyone at home as much as we could. There was no hospice during that time. There was no discussions or going to the doctor and talking about what your goals of care conversations are like. And then the woman that is on the far right, who's smiling brightly, that is my mom. And my mother, born in 1938, once again, way before hospice was started, right? But who got ill in 1985 with gastric cancer and had surgery. And then about a year and a half later was very ill. And I wasn't quite sure what was going on with her, except that the doctor had told her she had a nervous stomach. And we found out that nervous stomach was not really nerves. It was gastric cancer that spread to the colon. And at that time, you know, in that time, oncologists were not really talking about what your goals of care were. They were talking about treatment. And my mom was able to have surgery and have chemotherapy. And we, along with our faith and what medicine did, got 2 more years with her. But during that whole process, we did not talk about anything related to what her plan was. You know, I was a new hospice nurse and started my career in hospice right at around 1985. I had just left the oncology unit and was very much an advocate, and we were pushing and praying and all the things that we did as a family. And then when my mom relapsed in 88, and there was no more opportunity for chemotherapy, I really struggled with what we needed to be doing. But my mom changed the trajectory of our family because she started talking about what it was she wanted. I was the hospice nurse, but at that point I was the daughter, and I wanted to buy more time. This month is always very special to me, guys, because my mother died in the month of November, right after Thanksgiving. And so, you know, I was bargaining for more time, 29 years old. There's still 3 young sisters still at home. But she said, I'm ready to go. I want to go home. And home was going back to my grandmother's house because my stepfather had died the year before, and us really caring for her there with my aunt. So I realized that even though I wanted to be selfish, I needed to honor what she wanted. The physicians weren't talking with her about what she wanted. The team, you know, knew that I was struggling, so they didn't push me too hard. But she was the one who always was out front telling us what we needed to do. And she absolutely was a communicator in our family. So we went home and we did what she wanted. We kept her at home, we kept her comfortable. And within about 40 days, she transitioned and went home to be with the Lord, which is what she said she wanted to do. She was tired and she knew it was time for her to go. The picture in the middle is my current family, right? And you guys have heard me talk about Bernard and BJ and Sarah. And so I'm trying to change the trajectory with my family about having more conversations. So often we plan and have conversations about so many other things in our lives, but we don't talk about what we want the end to look like. I started conversations with my husband, Bernard, of course, and we've had the opportunity through these last 3 years. After 25 years of marriage, he had some very severe health challenges that came up in these last 2 years. COVID in 2021, where he was hospitalized, and we had to revisit what these conversations were like, and what it was that he wanted. And he wanted, of course, to do everything that we could do to keep him moving forward. And we're so grateful that he survived COVID. And then in last year, he was diagnosed with prostate cancer. It took way too long to get to a diagnosis, from April of last year to December to get a confirmed diagnosis after finding out he had an elevated PSA. And he had surgery in February of this year. Happy to say that he is on the other side of that, doing well. But once again, we needed to talk about what did he desire? What were the plans? And he did not have metastatic disease at all, was enclosed in the prostate. And so once again, we're grateful. But these are times when we need to have those conversations. I have an advance directive. My husband still has not done one, although we're getting closer because we're having more conversations. And we're telling our children, they think their parents are eternal, like nothing's going to happen to us. But we're preparing them that if something happens, there is life insurance, kids, and don't use all of it to bury us, but use it to live afterwards, right? And so this is so, so important. I want to challenge you, and I want to see in the chat, how many of you have begun to have conversations with your own family? You know, around the holidays, families are gathering. It's a perfect opportunity. Of course, I'm an old hospice nurse, so I think these are easy conversations, right? But I want to know from those that are on, there are about 24 of us on today, put in the chat, yes, I've had that conversation, or I'm planning to have the conversation, because of course we want to be the first partakers. Next slide. All right, Mary Bethel. I thank you, Mary. Yes, 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 it's important. So I love this quote by Ira Bayek that says, I have an advance directive, not because I'm seriously ill, but because I have a family. Oh, I love seeing these things in the chat that a lot of you have had the conversation. Some of you, yes, and Keith, thank you. We talk to update each other at least twice a year. Absolutely, because things can change very quickly. And so wonderful. Someone's going to bring the Hello game. It's an amazing little tool to use because it has funny things that you can ask each other. So that's a great one as well. So thank you guys for putting in that, putting your comments in the chat. Next slide. So often when we're doing these things with communities, we are talking to them, and this is a slide from our presentation. Karen says, I need to do an intervention. I do, Karen, thank you. Isn't it time we talk? Right. And so often as we're in communities, and particularly we're in faith communities now, with the work that we've done, Margaret, who did a phenomenal job, Shane, now Heather is working with me as we are doing these community talks. We are really challenging folks around this whole issue of conversation. We cannot get to a document unless we start chatting and talking with each other. Next slide. Oh, my time's going by quick. So let's just take a quick recap of what advanced care planning is. We make decisions all the time. We plan ahead for expected events, right? Like I just a couple of weeks ago took Bernard away for a weekend to celebrate his birthday. It seems definitely now that we've had these life-changing, potentially altering events that we do more things together. And so we went to New York and saw for the first time together a Broadway show, right? But it took me a few months to plan that. We planned for our children for their education. We planned for family reunions. But are we planning about the healthcare we want as we age? We all know that advanced care planning really is about giving our family, number one, that gift of conversation, and then making a decision around who's going to speak for you. We challenge our communities when I'm with the church members and with other community members to think about who is that person in your family that you trust to honor what you want. It may not be the person who's closest to you. It might mean that you choose someone else who is not going to feel pressured when the other family members come to them and say, no, we don't want that to happen. She wouldn't have wanted that. I pray for my husband because I have four sisters and they are very bossy. And if something happens to me, they are going to be all over him about the decisions. So make sure that the person you choose to be your healthcare agent is a person that you feel, no matter what the pressures are around what may be happening, they're going to hold fast to what you told them you wanted and what you wrote. And then, of course, you want to put your plans in writing. Next slide. So we already know that not enough people are talking. 90% of the people think it's important, but only 30% have had the conversation. We know that the Conversation Project has done some recent surveys, and we've come up a little bit in the percentages, but still it's flip-flop. It's not even 50% yet. 82% of the people say it's important to put their wishes in writing, but only 23% have done so. I will tell you that from recent studies, and I did not put it in here, that 56% of the people that were surveyed in 2018 said that they are ready now. They would love to have they would love for their loved one to begin a conversation with them. So there is that piece where we've seen a change even there. And then many people store their advanced directives in locked boxes or inaccessible locations. We cite here that fewer than 13% of patients who are 65 and older that were admitted to UNC's emergency room had an advanced care document that was available in the EHR. So once again, we are working on these kinds of things, but first getting people to chat, talk about what they want, and then also to document their wishes. Next slide, Heather. Thank you. So why are we not having conversations? These are the kinds of things that I want to let you know, and some of these may resonate with you. They resonate a lot with the communities that we're chatting with, that if I talk about it, I'll make dying happen too soon. In my particular culture, in my family culture, as well as with African Americans, there is this myth out there that if we talk too much about dying, we're going to cause somebody to go quicker and they're going to have to be buried real soon. And so we're trying to dispel these myths that only old people need to have an advance directive, or only someone who's sick needs to have an advance directive. An advance directive should be done by anyone who's 18 years and older. Young people are dying just as well as older people, and not all the people who are dying because they were sick. We also think that I won't get any more treatment if I have a directive. The directive really, as you talk with community members, is really to help ensure that they get the treatment that they want. And then also, my doctor and my family knows what I want. I don't know why we think that people are in our head, that they know what we would want when we haven't uttered what we want yet. And so we can't assume that the doctor's going to know, and we can't assume that our family's going to know either. And then if I name someone as my healthcare agent, several years ago, I was involved with an AARP town hall event in South Carolina. And one of the questions that came up from the participants. There were 14,000 people that were on this call. We were talking about immunizations, and there was a small piece there about advanced directives that I was a part of the panel. And the number one thing that came up from the people who called in is, if I have a directive, will I lose control of my care? You never lose control as long as you have medical decision-making capacity. And that is the thing that people sometimes, they aren't used to writing things out, and they're feeling that someone's going to take over even when they're still able to direct their care. Next slide. And so there are some barriers in terms of having these conversations. The fear of dying, the lack of knowledge or experience, the cultural and spiritual considerations, why people don't have these conversations. I hear a lot from our Hispanic and Latino community members that it's very similar to them, that this isn't a topic that is discussed a lot culturally among their family members. Then there is the lack of trust in terms of, is the physician trying to get me to do something that I don't want to do? Because there's a lack of trust in our African American communities based on historical things that have happened with healthcare considerations. Or that it's a barrier because the physician's in a hurry. Last night, Dr. Johnson did an amazing talk with her lecture. And one of the things that she cited, that the churches that she's doing surveys with, that the physician's in a hurry and doesn't have time to talk with me. There are those disagreement about decisions. And then the desire to maintain hope. If I put this down and I'm believing for God to do an intervention in terms of healing me, this document then takes away my hope that that might happen. And so we want to frame hope for people, that hope is not just about my physical cure, but hope is also about that I am going to receive the care that I desire, and I'm going to my family's going to honor what matters most to me. Family role issues. I can tell you that my grandpa, John Henry, that you saw his picture, he was in charge of our family. He had 10 children, and he was very clear about he was in charge. There was none of this compromise. Let's have a discussion. No, if John Henry said what you needed to be doing, that is exactly what you should be doing. And then ethical dilemmas come up as well. I can't even begin to imagine making a decision for a child, if I'm a mother or a parent, that it's time to stop the treatments, right? That it's not working. And so those are issues sometimes that are tough for us to deal with. Next slide. So this is what we propose to communities. And as you are talking with people, and I'm sure many of you are doing outreach, we have just a very simple 4-step plan as we are doing this work in communities through the Health Sciences Innovation Group. We're really grateful to the License to Give Trust Fund for the opportunity to really impact rural communities with this information. So we encourage people to think about their choices, what is important to them, to talk about their decisions with their loved ones, with their physician, and their spiritual advisors, to put their plans in writing, and then to find a place to store their documents. And we're going to talk about that we have an opportunity for that in the Carolinas by utilizing the Mind My Health platform, which is live and doing well in the Carolinas, and can be used by anyone across the country because it is a cloud-based system. Next slide. So I want to talk a little bit as we transition about what advanced care planning looked like in the past, and how we are progressing to the present, and what it is that is in store for us for the future. So in the past, there was limited training for our physicians and our nurses and social workers. As I shared with you, I started my nursing career in 1981. There was not one course in my class around how to have advanced care planning conversations, not one. You did on-the-job training. I had to learn at the bedside of my dying cancer patients how to support them. And so we're so glad that things have changed now in the present, that there is not all that we want, but more training and education for our clinicians. There was no emphasis on cultural competency and cultural humility as we began to look through a health equity lens and how we engage with patients and caregivers around these topics. to consider what someone's family structure is like, to consider what their ethnicity is all about and their culture in terms of how they deal with death and dying in their community. I can recall the very first time I had to see an Asian patient, and I was seeing them in their home as a hospice nurse. And when I approached the door, that in order to go in, there were all these shoes at the front door. And I didn't realize that that's a cultural piece. So back then, of course, we weren't as concerned about the infection control. I took my shoes off and walked in with my stocking feet and provided care. My Jewish patients that I cared for, and I did not realize that in my culture, it's unusual for someone to be buried within 48 hours. But in a Jewish culture, they're buried within 24 hours. There is no embalming. They are, caring for the body. And I had an opportunity to talk with a Jewish community health worker last night who's working with one of our projects. And she talked about the ritual of washing the body. And so we did not get that kind of information as we were training about how to incorporate those pieces into what matters most as we care for patients at the end of life. And then there were silos that existed between the healthcare team and the community, and especially silos between the healthcare team and the faith community. We didn't see how those things go together. We understand with the care that we provide with hospice and palliative care that spirituality and emotional and physical and medical support, all of those things are integrated. And we have this amazing interdisciplinary team care planning process to ensure that all of those aspects of care delivery are touched on with a patient and family. But in the past, there were those silos. And this is not an all-inclusive list, just a way for us to begin to think about that. And now the next slide, because our time is going quick. Woo. So here we are at the present. So in the present, we have some amazing evidence-based tools that we are training our clinicians with. I know our colleagues are utilizing Vital Talk. There are folks that are using Respecting Choices. There are folks that are using the Serious Illness Conversation Guide. And so we also have LNEC that is out there as well, training nurses on how to have these conversations. And many of those are being rolled into nursing curriculums, especially LNEC is being rolled into nursing curriculums. And our health systems are utilizing these evidence-based training tools to train their current clinicians. So a huge, huge difference from what we were doing 20, 30 years ago to what we are currently doing. The other thing that is in the present is that we are having partnerships with community-based organizations and faith organizations. We are doing outreach and we're collaborating together on doing this work. Our project through Health Sciences Innovation Group is a community care project, which is an outreach to rural communities, not just for faith communities, but our faith communities have been so eager to receive the information. And we're not only just talking with them about advanced care planning, but we also are talking with them about organ donation. I've learned a lot about the importance and the value of organ donation, because personally in my own community, it's not something we talk about in terms of giving our organs away. And the importance of being able to do that. In North Carolina alone, there are 3,000 people waiting for an organ. So the need for that. So our community partnerships are a lot different now. There is great funding support for grassroots campaigns to reach our underserved communities. And so, years ago, we had lots of great funding for pain management. Things that were done through the Robert Woods Johnson Foundation. But there are funders now that are funding end-of-life care, especially around advanced care planning. And so the Duke Endowment doing their work, the Blue Cross Blue Shield, the Harmon Foundation, the Rita and Alex Hillman Foundation, and others that are funding work in communities around advanced care planning and care coordination. And then there is payment now by CMS in the present. In 2016, CMS said, hey, we will start giving some reimbursement to primary care physicians and specialists to initiate advanced care planning conversations at least yearly. And then if they're done at other times, we'll still reimburse them, but there'll be a copay for the patient. We also have health systems that are now, 20, 30 years ago, we weren't uploading and having storage places in our EMRs for advanced directives. So I see that we're making progress. And then, of course, we have cloud-based advanced directive registries that are available as well. Five Wishes has just turned theirs into a cloud-based platform. And then, of course, we have the Mind My Health platform that is also a tool that we're using here in the Carolinas. Next slide. So we've talked about the past, we've talked about the present. These are, just want to let you know, give a shout out to the License to Give Trust Fund Commission, as well as to the Duke Endowment that is doing work in end-of-life care across the Carolinas. Carinova is doing some new work that's going to be looking at the work that health systems do with communities around end-of-life care. And so many of you are going to be hearing about that work as it rolls out. I see a question there about how is the research and JAMA article published by Dan Meyer shaped your perspective on advanced care planning? Is that you, Dr. Fox? I'm going to hold that and I'm going to come back. I'm going to come back to it. Mind My Health is a technology platform that we're utilizing in the Carolinas. Next slide. And then this is what it looks like when you go to the site and mindmyhealth.org. And then when you, let's go to the next slide. When you see this here, you'll see how we've developed that online platform. We have the capability to interface with healthcare systems, but we're working on some legislation to be able to do that with our healthcare systems in North Carolina. And then our goal is to increase the number of people who complete their document and also be able to list their organ donation preference as well. And we can have rapid access. Next slide. So I want to talk about the future, and then I'm going to touch on Dr. Fox's question. So what do I see in terms of the future from what has been happening? Number one, I see the expansion of, and this may touch on your question, Dr. Fox, the expansion of advanced care planning conversation training and post-secondary training curriculums. This week, I had an opportunity to sit with some undergraduate social work majors, students who want to go into social work. And last year I had the opportunity to do that with social work students at South Carolina State. This year it was the University of South Carolina. And so young minds, I think we have to get to our interdisciplinary team members who are interested in healthcare. We've got to get to them sooner rather than later. And one way to do that is to find ways to add it to their curriculum or add it as supplemental material to their curriculum. The instructors that invited me to come in, as a community expert to really entertain their questions and to open their minds to the field. And I believe we've got to do more of that. We also have some work that we're doing with third-year medical students in South Carolina at MUSC, where Wilma Rice has really been doing a lot of that work around helping them to see how to do their own advanced care plan, but then also how they interface with seniors as well. And so I think that is the piece that we've got to do, is to put it in the curriculum. We need to increase those conversations that happen in primary care offices. This is going to be a lot easier with the physician fee schedule that came out. One of the things that's in that is the primary care physician offices can now use community health workers or navigators, and they can extend some of the work that they're doing, that even if they don't have enough nurses, they can utilize these individuals to help people with the resources that might be needed to make those connections. So that is something that is going to be needed. the care models that are now being created and some of the work that's being done on the national front. There is the dementia guide model that was just released a couple of months ago that is going to be something that will allow for advanced care planning further upstream, and the utilization and payment for communities to come together and to do this interfacing with caregivers and their loved ones. And this will allow for greater access. There is a congestive heart failure pilot right now that's being done with the American Heart Association, a grant that's being done looking at what ought to be those pieces to consider for when to make a palliative care referral, but also when is the right time to begin the goals of care conversations. And so looking at those pieces as well. So I believe we will see that, more of that in the future. I do know that the Oncology Association is for clinicians is also looking at this as well. And then I do believe that there is value in doing more work in communities. I have found this year, and I've done more than 10 events with community churches this year, some small and some big, and we already have some on the docket for next year. They are hungry for this information. They are wanting to help their parishioners, and pastors realize that they've got to prepare their parishioners, but they don't want to do it in silos, separating faith from these discussions, but they want to integrate the spiritual components of their faith and how you can see in their Christian faith elements where transitions are talked about in the Bible, and how we bring those transitions into why we do advanced care planning. That planning is something that is a spiritual process and that should be done around end of life care. So pastors are really wanting to be engaged. They are wanting curriculums that are written. I see that we can do more of this. The funding is always the challenge, but I do believe that if we do train the trainer programs, when we leave a congregation, we give them the tools that they can continue this work and can continue training their members and raising awareness of the need to execute their documents sooner, as opposed to when there's a medical crisis. We will need to use other paraprofessionals to help us, like community health workers as ambassadors, to extend the work that our clinicians are doing, only as they are trained and having accountability checks that are made with them as well. And then there are individuals, a small contingent of funders who still want to fund care coordination and these kinds of efforts nationwide. And we really need to tap those resources in our states as well. Interoperability for technology and storage is going to increase for rapid access. We are seeing that take off across the country. Most of the states are really, through their health systems, the EMRs are able to talk to each other if they're with the same company, but also there is the information health exchange where we're seeing connections as well. And we want to see that this can work anywhere across the country. And then nationally, we need to be looking at legislation and looking at payer alignment that will enhance and increase opportunities for these conversations and ease of executing these advanced directives. The Uniform Law Commission just put out their recommendations that really look at expanding the different types of people who can serve as a proxy, looking at the language in terms of how healthcare advanced directives are written, making it easier for lay people to understand the language. Now, the challenge, of course, when you get something from a national perspective is now that at the state level, we have to look at our Uniform Law Commission statewide and begin to see what it is we need to do with our documents. I know in North Carolina, our desire is to make it easier for documents to be executed. So that's going to take legislation so that we don't need 2 witnesses and a notary to execute a healthcare power of attorney. So those are issues that we're looking at. During the pandemic, of course, we were able to do online or virtual notarizations, that's gone away. And so all of the technology that will ease and will help us be able to do those pieces as well, and to streamline the paperwork that's out there, and then being able to eliminate co-pays for having advanced advanced care planning conversations. So those are the things that I see in terms of the future. There has been, as Dr. Fox has alluded to, controversy in terms of the benefits of doing advanced care planning, and especially on the back end in terms of, are we really honoring what people want? And why should we be doing advanced care planning? I will tell you that I have mixed emotions about it. I do agree that if we're going to have an advance directive, we need to honor what the person wanted. I absolutely believe in that. And that is the accountability piece, that if we're asking people what they desire, that we honor what they say. And that's a piece we haven't tackled yet. And I will tell you, it's something that we definitely need to do. I do believe that there is great benefit, though, in raising awareness in our communities, especially, and empowering people to make decisions about what matters to them by, number one, speaking with their family members, and number two, getting to a document. We see too many people who come to the emergency room, and this has been verified as we're doing these community meetings, where we ask them to tell us their stories. And when they begin to share their stories, they're beginning to tell us, I did not even know what the person wanted, and they ended up in the ER, and I was forced to make a decision, and I felt inadequate to do it. I think we have to begin, and the way to do that is to do that with partnerships with credible influencers in the community. In many communities, that could be a spiritual caregiver like a pastor. It could be a fairly qualified healthcare center where people are going all the time to get their primary care done, and they have a relationship with those individuals. That we've got to create those partnerships to spread this message, so that we're empowering people from the community perspective, but then we also then are educating our clinicians on how to initiate these conversations, where when those conversations are had, it's not a strange conversation. So I see this comment, even with the new studies in mind. I can't read it completely. Let's see, can you read it?
It says, thank you. I and Advocate Health Midwest have also been troubled with the messaging because we believe in the significant value in upstream empowerment. It's a very difficult question, and I appreciate your leadership and guidance on this.
Yeah. This is a piece that is so important, and particularly as we talk about health equity and disparities, if we don't begin empowering people with the knowledge, many people don't have knowledge about how this works and how the health system works, and how they have the ability to choose what it is that they want. Now, on our end, sometimes we're a little bit biased, because if they choose to want to have everything done, right, and we feel that everything done would be futile, but we're saying we want to honor what the person wants, then that means that once we've explained it and they understand the explanation and they still choose to do what it is they desire to do, then we should honor what it is the person wants. Dr. Kimberly Johnson touched on this last night, because we feel that in our position as clinicians and all that we see, that there's futile care out there sometimes, but we don't factor in, and I know there's cost for that, guys. It's tough. It's an ethical dilemma. But if we're saying that person-centered care is what we ascribe to, and we are explaining to people in terms that they understand, and they don't choose the choice that we would choose, it's not about our choice. We've done the pieces that we need to do. So lessons learned. I got to move through this. It's 11:50. Thank you, Heather. So what have we learned this year? And what am I learning as I talk with communities? It's been so rich hearing their stories. And it's been so rich seeing 80 and 90-year-olds execute their documents. I mean, we're going in and they're hearing this information. They're saying, I'm going to do my document. And they're bringing their families to these meetings. And there's no place else where this kind of stuff is happening. It's happening in community because we're taking it to the community. So I can't tell you how special this is for the work that's being done. But here's what we've been learning. And this is what I've been hearing this year. Number one, we have to prioritize building relationships with credible influencers and experts in the communities that we want to serve. That it's not the short route, though. We want a quick fix. It takes time to build relationships. And so there has to be a commitment that we're going to do it the right way. And we're going to get started and we're not going to give up on it. We're going to keep going. We've got to give the experts a seat at the table. And these are those community experts, a seat at our table to advise us on these community projects that we want to implement. Some folks, especially in the Carolinas, have set up advisory councils with the community to give them feedback on how they're doing and what they need. And if we're doing research, I've been hearing this loud and clear recently, and especially at the summit a couple weeks ago, the CTAC-CAPC Summit, that a lot of communities feel like when folks are doing research, they don't include them in their budget, so they don't value their time and they don't build in monies to compensate them accordingly. And so if you're doing research and you're wanting to use the same communities, that you understand that to do that may mean that as you're getting money to do the research, that you also include them in the budget. We've got to listen to their stories. We've got to build in that time to hear them. And when we do that, that will help us incorporate into our practice what will work. They're going to share with you through their stories what didn't work and what works. And then we must be intentional and accountable to do the follow-up. Sometimes we go into communities, we do what we want to do, and then we're gone, and the relationship has ended because we aren't still cultivating the relationship. And that reinforces the concept of not having trust with the people who come in. So we want to make sure that we continue to build on those relationships. And then we must practice cultural humility and train our teams to do the same thing. That we don't know it all. We're not an expert on that person's family culture. We're not an expert on what happens with their particular ethnicity or the community that they're in. And so this is for any community. I'm talking today because from my perspective and the lens that I wear every day around Black and Brown communities, I see that a lot. I've lived it in terms of my own family and the things that happened. And I didn't have time today to tell you about some of the inequities that I experienced, even as a nurse in trying to get care for my husband, right? And I know what to ask for. And I still had some roadblocks that I had to get around. So because people did not hear me about what was needed. So these are lessons, and there are many others, but this year, these are things that have really stood out to me. Next couple of slides, and then I'm going to be done, Heather. I love this quote by Brené Brown, and I've been sharing it a lot this year. I got it last year when I went to a philanthropy conference. For the first time, I'm serving on a foundation that gives out money. And they sent the trustees to this particular conference. And I saw these posters in the hall when I walked through, and I took pictures of them. And this was one: trust is earned in the smallest of moments. It is earned not through heroic deeds or even highly visible actions, but trust is earned through paying attention, through listening, and gestures of genuine care and connection. It's really what makes the difference. And the next slide, which is our final slide for today. This is from Dr. Richard Payne, the lectureship that I went to on last night here at the Duke Divinity School. People are people. They are not just a collection of molecules and tissues and organs. We have to understand what the person with the disease or illness wants to accomplish. Dr. Richard Payne. Thank you so much for the time today. And we may have a time for maybe one or two questions before we wrap up because we promised you 1 hour. And so I'm happy for we can stop sharing. And I am happy to hear from the audience.
All right, and let me start with a thank you to Marisette. That was wonderful in terms of sharing where we've been, where we are now, and where we are going. I know for me, I have all of these ideas about how best to move forward and the collective action it will take. What excites you or concerns you when it comes to bringing folks together to really make meaningful change?
Mm-hmm. What concerns me? I have no concerns about that. I think wonderful things happen when we bring groups together. And that is what motivates me to keep going. It's tough work. It's not something that is going to get done overnight. But I know that collectively we can change the laws, but changing laws takes time, right? It took us a long time in South Carolina to get post passed, right? But we did it. You just have to stay after it. There are states now that are working on Medicaid palliative care benefits across the country. There are 15 states that are working on that. And that means that at the state level, they're going to have to impress upon their legislators to put that in the budget. But they are working on it because it's important. It will increase access for so many people, particularly those who live with high health disparities, to have access to end of life care and to have that support through palliative care. And so I believe that we just have to, bite that elephant one bite at a time. And we're going to get there. So.
Well, thank you. I know for me, professionally, this was motivating. And I know for me personally, as a family caregiver, this was motivating. I think there is a lot of work to be done. And so to keep our energy up, given that this is November's National Hospice and Palliative Care Month and National Family Caregivers Month, I think there was a reason why we had the symposium during this month and this time. And I cannot thank you enough for ending this symposium in a really powerful way. As I said in the beginning, weaving in so many of the components. And we started the week about building our village and how we can all work together. And then how we can get our own documents in order and how we can work with our partners in the academic space, in the healthcare space. And really, you highlighted the power at the community space as well. So
yeah.
thank you.
Thank you so much to everyone who got on today. I know everyone is really busy, and this week I really have been all over the place this week, but I knew we encouraged our folks from South Carolina to jump on, and so some of them were on this week, so that they're again joining our voices together and putting our efforts together. We do not need to reinvent the wheel. We need to come together. I really believe in collaboration over competition. And so where we find that somebody's doing something really, really well, can we come together and really strengthen and amplify that impact, by coming together? So I absolutely love the theme of this week and so appreciate the opportunity to be with you today. And call on us if we can help you with anything. This was just sort of a quick overview today. We can do deep dives into a lot of these things, and we're happy to do so.
Well, thank you again, Marisette Hassan, for sharing your insights. Thank you to everyone of the North Carolina Serious Illness Coalition who helped to put our Joining Our Voices symposium together. With each of the work groups, you're getting hand claps and thank yous coming. And for everyone, there's more to come. As a coalition, we serve to amplify lots of issues. And so I encourage you all to go to our website, ncsicoalition.org. Soon, not tomorrow, we want to give Jessica time to breathe, but soon all of the recordings from the sessions all week will be up on our website, as well as other ways you can get involved. And with that, thank you, everyone. Thank you.